Welcome back to ENT Shorties. Today we look at what I have seen are some of the most common mistakes in treating nasal allergy patients. Remember, all allergy management revolves around 3 strategies, and in this video we'll look at each one. Here are the top mistakes I see with environmental control measures. Too high a reliance on air purifiers. They can be valuable, but I think this is overestimated. Secondly, cleaning moldy areas, but not addressing underlying water or moisture problems. Mold soon recurs with this approach. Third, spending large sums of money on wrong measures. I think patients feel if they spend money, it must be valuable. And finally, inconsistent use of techniques. The key to any environmental control measure is sustaining it. Medication errors with allergy are so common. I highlight a few of my major concerns. 1. Oral decongestants are often overused, especially for patients with cardiac issues or hypertension. Patients often end up in the ER with palpitations, hypertension, or chest pain and get an expensive cardiac evaluation with no abnormalities found other than pseudoephedrine use. 2. Topical decongestants offer instant relief from nasal obstruction, but they cause long-term problems. I have an entire video on this one. 3. Antihistamines are used inappropriately for nasal obstruction. They're best used for the watery symptoms of sneezing, runny nose, and itching. You have to tailor medications for the symptoms. If you forgot how to do this, go back and see the video on allergy medications. 4. Many people will change antihistamines from one to another out of concern for developing tolerance or tachyphylaxis. This hasn't been proven to occur with antihistamines. I recommend find an antihistamine that works best for you and stick with it. 5. Older sedating antihistamines are often used for sleep, but the quality of sleep has been shown to be poor with diphenhydramine. Hangover effects of sedation and impaired reflexes have been shown the next morning when taken before bedtime. 6. Overuse of medications such as multiple antihistamines increases side effects with limited improvement of symptoms. 7. Inconsistent use or waiting to start medications until symptoms develop is fraught with failure. Finally, 8. The goal is the proper medication for the symptoms used correctly. Here are the problems I see with immunotherapy treatment. Immunotherapy is designed to develop tolerance after 3 to 5 years of therapy and should persist for years after stopping. I've seen tolerance last a few years to over 20 years. Some patients report being on therapy for 20 years or more with no attempts to stop their shots or drops by their providers. This seems self-serving for the provider and not based on the theory of treatment. On the other hand, other patients tell me their physicians stopped immunotherapy after 5 years despite ongoing symptoms and refused to restart therapy. I don't believe everyone's immune system has read the studies saying 5 years is adequate. Surely there's an approach somewhere between these extremes. After 4 to 5 years of treatment, I stop therapy and monitor for symptoms. If patients worsen, we start back for 1 year and then try again. Generally, most patients will reach tolerance at least by 6 or 7 years. Other problems are inconsistent use of treatment. An occasional miss is okay, but lapses of weeks to months at a time decreases the success of treatment. Finally, expectations for success must be understood. Treatment doesn't mean that patients will never be sick again. Viral respiratory illnesses and severe allergy exacerbations can still occur, and it doesn't signify therapy failure. You must explain this carefully to patients and judge success over the long term. Now you have the keys to understanding allergy mistakes. Environmental control must be consistent. Use proper medications properly, and immunotherapy builds tolerance for the long term.